Okay, kita putus kopi dulu.
Taruh gitu dong. Okay. Oh, tu link YouTube dah.
Dia. Tak, tunggu dia. Dia lagi dah. Dia datang. Ada video tak? Ada video.
Tengok ni. Ini screen tu. Okay.
Assalamualaikum warahmatullahi wabarakatuh. Tuan-tuan dan puan-puan, sesi CME kita akan bermula sekali lagi. Mohon semua mengambil tempat duduk dan mohon kerjasama untuk mengumumkan tempat duduk yang kosong di bahagian hadapan, dan pastikan telefon bimbit pada berada keadaan dalam silent semua. Untuk kehadiran, mohon imbas kod QR yang dipaparkan di skrin, dan kod QR juga tersedia di kedua sisi dinding dan juga pintu auditorium. Assalamualaikum warahmatullahi wabarakatuh, dan selamat pagi kepada para tamu hormat kita yang berusaha Dr. Izzanuddin Idris, Marah Hospital Zainul Zainab 2, Yang Kuasa Dr. Muhammad binti Muhammad Faizal, Timbalan Perubatan 3, Ketua Perjabatan Pakar-Pakar dan Kawan Perubatan Suruh Perhimpunan HIV 2 dan dihormati. Pertama sekali saya ingin mengucapkan terima kasih kepada semua kerana sudi memakan masa menghadiri sesi CME kita pada hari ini. Saya Dr. Ahmad Arif dan Muhammad Zaki akan menjadi pengacara majlis adat pada hari ini. Tanpa melengahkan masa, saya ingin menjemput Dr. Nabilah binti Cik Abai, pakar perubatan klinik nefrologi daripada Jabatan Nefrologi dan juga Raja Tunggal Zainab II untuk menyampaikan CME hari ini yang bertajuk Kidney Disease in Pregnancy dipersiapkan dengan Dr. Nabilah binti Cik Abai.
Assalamualaikum. Assalamualaikum kepada semua. So saya Nabila. So currently first year trainee based in Hospital Pasir Mas. So I'm going to present briefly regarding pregnancy and kidney disease. Briefly regarding each subtopic. So this is my outline of presentation, which is about local statistic in HRPZ regarding maternal with kidney disease, renal adaptation in pregnancy, AKI in pregnancy, lupus nephritis, CKD, dialysis and pregnancy, and also conclusion. First, I'm going to start with the preliminary study, which is this is an unpublished data we conduct in HRPZ, which is the outcome of kidney disease and pregnancy in HRPZ2. So this is a cross-sectional analysis which we took all the kidney disease and pregnancy referred to nephrology clinic HRPZ2 from April 2023 until currently 2025, which were taken and analyzed. So this is our findings so far. So we have 38 patients, which mainly in the middle age group, about 24 patients in the age of 31 to 40 years old. So cumulative patient in the reproductive age is about younger reproductive age between 20 to 40 years old, with about 37 patients. So this is the cumulative of diagnosis in 38 of patient, which is highest is among the hemoproteinuria patient. Among the hemoproteinuria patient, we accounted for 34% of the patient. Then the second highest is about 21% of CKD patient. 18% of lupus nephritis patient, and others in a small percentage range between 2.6% to 7.9%. So this is the pregnancy outcome, which is about 6 patients still ongoing pregnancy currently. We had 39% of patients, which is about 16 patients, had a premature delivery. 10 patients, which is accounted for 36%, had a term delivery. 13% unfortunately had to go termination of pregnancy. One patient is unknown due to patient shifted to different state of follow-up. So kidney outcome in the postpartum patient, which is still 6 patients still ongoing pregnancy. However, we have 28% of patients back to their baseline of renal function. But there are significant percentage of patients, which is 18% of patients, which is accounted for 7%. 7% is need to be placed on renal replacement therapy. So 50 patients achieve remission, which is quiet disease. So I'm going to start first with the physiology changes in pregnancy. As we all know, when a woman becomes pregnant, there are systemic change, which is increase in red blood cell about 20 to 30%, hence increase in plasma volume about 40 to 50%, which lead to physiological anemia. And also there are increase in the cardiac output, hence decrease in blood pressure. So specifically to renal adaptation in pregnancy, in which we can divide into anatomical, hemodynamic, or hormonal changes. So for the anatomical changes, kidney become enlarged by 1 centimeter in length due to increased vascular and interstitial volume. So there are also physiological hydronephrosis of pregnancy, more on the right side, due to renal pelvis and ureters dilate. There are increased risk of urinary stasis, hence predisposed to UTI. There are also increase of nephropermeability, which can be seen by proteinuria up to 300 mg per day, which is about 2 plus on deep state UFAB. So hemodynamic changes as mentioned in before, which is renal blood flow, renal plasma flow can increase up to 50 to 80%. The increase in glomerular filtration rate about 40 to 50% by second trimester, and hence serum creatinine and urea fall about 20%. There are increase in glycosuria due to increase in filter glucose load and reduced tubular reabsorption, and also physiological aminoaciduria. There are increase in the renin-angiotensin aldosterone activity lead to sodium and water retention, hence plasma volume increased by 50%, and also increase in vasodilator, which contribute to renal vasodilation and hyperfiltration. So this is the summary between hemodynamic and renal physiological changes in pregnancy. So why there is a challenge in interpretation of kidney function in pregnancy? Because the increase in glomerular filtration rate, so we lead to a fall in serum creatinine. So 24-hour urinary creatinine clearance actually is a gold standard for renal function measurement in pregnancy, but it is inconvenient. So how do we consider patient has a CKD, CKD in pregnancy? When there is a lack of fall at 10% from the pre-pregnancy value associated with preterm delivery and greater EGFR decline. So EGFR is not recommended for a standard measurement during pregnancy because it's underestimated through GFR in pregnancy because of the physiological changes. So how do we stage the pregnancy? CKD in pregnancy, usually we use the pre-pregnancy value. So we can observe the increase in proteinuria in pregnant patient due to increase in a change in hemodynamic, altered permeability of glomerular barrier, and impaired tubular reabsorption. However, there is no acceptable threshold for gestational increase in proteinuria with established CKD and proteinuria. Cystatin C has been postulated but not validated in pregnancy because it has been shown increase in third trimester and higher in twin pregnancy compared to singleton. So this is how pregnancy creatinine should occur. The monitoring of creatinine should drop about 15 to 20% during pregnancy. So it ranges from 50 to 70 during the early pregnancy with peak around 80 towards the end of pregnancy. So moving on to the AKI in pregnancy, which can happen occasionally. So what is the major cause of pre-renal AKI? Pregnancy AKI. So it can be divided between pre-renal causes, renal causes, or post-renal causes. It also can be seen whether it's a pregnancy related or non-pregnancy related. So basically, when pregnant patient came in with AKI, so we have to look hard for whether it's a pregnancy related or a pregnancy unrelated, especially in pregnancy related. What's important is to exclude the preeclampsia. So this is the similar cause of pregnancy AKI, which further divided into according to trimester. We can see the cause of AKI in first trimester usually pregnancy related, usually related to hyperemesis gravidarum. So in second trimester, it can be due to infection inside, or throughout the three trimester, it could be due to flare of lupus nephritis, and specifically in second or third trimester, it can happen most commonly is preeclampsia. So what we do in patient with pregnancy AKI, we can only monitor and treat the precipitating causes. Meanwhile, we're moving on to lupus and pregnancy. So there are complications towards maternal and fetal complication in which there are 25% of risk of lupus flare in maternal with lupus nephritis, risk of hypertension, pre-eclampsia about 7.6%, eclampsia about 0.8%. The fetal complication can be happen spontaneous stillbirth, neonatal death, intrauterine growth restriction, and premature birth about 39%. So for patients with lupus nephritis, they should be in remission for at least 6 months before conception on medication known to be safe to pregnancy. So hydroxychloroquine is a must. It is to reduce the risk of lupus flare and fetal growth restriction. So prior pregnancy, anti-Ro and anti-La antibody should be checked to weigh the risk of fetal heart block and neonatal cutaneous lupus. This kind of patient need more surveillance during pregnancy than pre-pregnancy. So this is an example of medication that being used in patient with lupus nephritis, which commonly patient would be on prednisolone, maintenance, azathioprine, tacrolimus, cyclosporine, MMF, or cyclophosphamide. So there are medication that not safe in the pregnancy. Hence, this kind of patient should have a pre-pregnancy plan before decide to conceive. So for SLE patient, so the risk of relapse or worsening during the pregnancy, if patient already in complete remission before more than 6 months before conceive, about 7%. If patient only in complete remission, about 40%. If patient in partial remission prior pregnancy, there is a 33% risk of relapse or worsening during pregnancy. And if patient still having a nephrotic range proteinuria prior pregnancy, there are 66% risk of worsening during pregnancy. Next, I focus more on the CKD in pregnancy because this is the largest group of patients in our study. So, chronic kidney disease is because it's often clinically and biochemically silent. Anti-renal impairment is advanced. So, about 30% of childbearing, 3% of women with childbearing age are believed to have CKD. So usually patients are asymptomatic, anti-EGFR decline to less 25% or already more than 50% of renal function loss. So conception is possible even in advanced CKD or while on hemodialysis. Only that they need to be on strict pregnancy care. So what are the causes of CKD in pregnancy? It can be due to many causes, whether it's glomerular disease, such as patient with diabetes, patient lupus nephritis, IgA nephropathy, FSGS, or membranous nephropathy. Or it could be secondary to chronic hypertension inside, or it could be the congenital or structural causes, such as obstructive uropathy due to stone or congenital anomalies, or polycystic kidney disease such as ADPKD, or it could be in transplant recipient or post-infectious or chronic GM. So in patient with CKD, basically they should receive a pre-pregnancy care, pre-pregnancy planning. So pregnancy can be considered in women with mild renal impairment with serum creatinine pre-pregnancy less than 124 and below, well-controlled blood pressure prior pregnancy, and without significant proteinuria based on CPG we took less than 1 gram per day. So pregnancy should be avoided in either moderate severe renal impairment, poorly controlled hypertension, heavy proteinuria, or active systemic disease. So this kind of patient should be co-managed with multidisciplinary team. So why pregnancy in CKD is difficult to difficult to diagnose? Because usually patients with CKD, they had irregular menstruation, early symptom of pregnancy, like nausea, vomiting, are similar to uremia symptom. So usually patients presented at the advanced stage of pregnancy. Urine pregnancy test and serum HCG are not reliable, which is it can lead to false positive due to substantial proportion of beta HCG dependent on renal excretion. Hence, we need an ultrasound to assess and confirm gestational age. So we classify the CKD staging based on serum creatinine pre-pregnancy, which is mild less than 124, moderate 124 to 220, and severe is more than 220. So the successful obstetric outcome is higher in the mild stage of CKD, which is 96%. And as the pregnancy CKD advances, the obstetric outcome reducing percentage. And there are higher risk of permanent loss of function as the pregnancy advance seen in the moderate and severe CKD, ranging to 25 to 50%, 55%. And patients usually develop end-stage at 1 year by 40% in severe stage of CKD. So this is the effect of CKD in pregnancy. As you all can see that the stage 4, the advanced CKD is stage 4 and stage 5, colored as yellow, and we can see that all the obstetric maternal and fetal outcome is higher as the advanced stage of pregnancy. So for summary of the CKD, despite in the early stage of CKD, which is stage 1 or stage 2, about 7.6% progress to advanced CKD throughout the pregnancy, there are still higher risk of cesarean section, prime delivery, and need for neonatal ICU care with small gestational age and smaller birth weight. So despite in stage 1, they are still independently associated with adverse outcome. However, it can be seen a higher rate of cesarean and adverse outcome in the severe CKD. So this is for the stage 1 and 2 to 3, eGFR decline is not significant as compared to advanced stage of CKD. And among all causes of CKD, pregnancy outcome is worse with diabetic nephropathy. So hence, patients with diabetic nephropathy need to achieve good BP control, A1C less than 6.5, and good retinal examination prenatal and antenatal. So moving on to the dialysis in pregnancy. So the dialysis in pregnancy, end-stage renal patient with pregnancy reported as ranging from 0.4 to 3.6%. The rarity of end-stage patient with pregnancy due to fertility problem and high rate of pregnancy failure due to stillbirth, fetal and neonatal death. So, however, as time as medicine advancing, there are successful pregnancy rate due to improved medical care, intensive dialysis regime, better blood pressure control, adequate maternal nutrition, and multidisciplinary monitoring. So, among two modality of renal replacement therapy between hemodialysis and peritoneal dialysis, there are improved in live birth seen in hemodialysis patient due to intensive dialysis time, which is more than 20 hours per week. Usually, patient while pregnant on peritoneal dialysis, at a certain point, patient usually will be converted to hemodialysis due to hemodynamic issue such as overload or inadequate clearance. So, among the kidney transplant and pregnancy patient, so if the patient and stage patient underwent a transplant, usually fertility is restored by 6 months post-transplant. So there are two different guidelines, which is based on KDIGO. We advise to delay pregnancy until first year post-transplant, while European guideline advised to delay pregnancy until second year post-transplant. So the predictor of good maternal and fetal outcome in post-transplantation is a younger maternal age with stable graft function, with no recent episode of rejection, serum creatinine less than 133, normal or well-controlled hypertension, and proteinuria less than 0.5. So in patient transplant patient, so there are similar risks of hypertension, preeclampsia as seen in CKD patient. This is proven based on across 3 studies. So for the kidney outcome in transplant post-transplant patient, so there will be a small rise of creatinine observed, which may indicate a significant degree of kidney injury. So in this kind of patient, we should have a low threshold for suspected allograft dysfunction. So the acute rejection rate in transplant patient is varies, but similar to a general population. So the graft loss rate within 2 years post-transplant ranging from 5.5 to 9%. This is from the 3 similar studies. For the fetal outcome in patient post-transplant patient, so there are higher risk of live birth, miscarriage, and neonatal death or stillbirth. So pregnancy post-transplant carries an increased risk of preterm birth, low birth weight, and baby born at lower gestational age. It's about 51%. So should patient donate a kidney if they have not completed a family yet? So as we compare in the pre-donor, non-donor patient and donor patient, there are increased risk of maternal morbidity, which is preeclampsia, cesarean section, PPH, prime delivery, low birth weight in a donor group as compared to non-donor group. So usually it's advisable for a donor to complete family first before donating a kidney. So this is similar in the 3 studies comparing the maternal and fetal outcome across 3 countries, which is the post-donation risk is higher compared to pre-donation risk in all outcome. So what influenced the pregnancy outcome in kidney disease patient? So first, maternal renal status. So as we know earlier, CKD stage play a significant role, which is more advanced stage equals to worse outcome. So proteinuria, heavy proteinuria more than 1 gram linked to severe adverse outcome, which may lead to preeclampsia, IUGR, and prime delivery. And also hypertension, BP control prior pregnancy. Also the type of kidney disease, whether it's inherited disease such as ADPKD, which it depends on the renal function upon conception, or whether it's a systemic disease, lupus nephritis, whether it's in remission or still in active disease, or diabetic kidney disease, which confer a higher risk compared to other disease. And other factors that contribute to pregnancy outcome, which is timing of conception, which is the best if disease stable more than 6 to 12 months prior conception. Transplant outcome, best if more than 1 year post-transplant and stable graft, no recent rejection. Use of teratogenic drug already been adjusted prior conception, and patient had access to multidisciplinary care, comprises of nephrologist, maternal fetal medicine. So what we should do if this kind of patient keen for pregnancy, so what we do is counseling and planning, which is discuss the maternal and fetal risk and explain the possible need of dialysis or high risk of preterm delivery. Need for multidisciplinary consensus in between the nephrology, ONG, maternal fetal, dietitian, and neonatologist, and discuss a contraception until optimal time for conception if the patient not suitable for pregnancy yet. So the timing of conception has mentioned before, which is ideally planned for pregnancy when the disease is stable, BP is controlled, not a heavy proteinuria, for the transplant weight at least for more than 1 year, and for lupus nephritis for more than 6 months in remission. So what we should do, part of pre-conception counseling is to review the medication to avoid teratogens, which is ACE, ARB, MMF, and cyclophosphamide, and we switch to safe alternative medication, and also optimize the BP control, diabetic control, and autoimmune disease, correct the anemia, optimize bone mineral metabolism in end-stage renal patient, ensure vaccination up to date, and also nutritional counseling. So what we should do is arrange for multidisciplinary care. So ideally monthly and then fortnightly for second trimester and weekly for third trimester. So blood pressure optimization by using the safest drug, example labetalol nifedipine, keep BP less than 135/85, and proteinuria keep less than 1 gram. So this is example of medication which is an ARB is toxic in the second and third trimester with limited data in first trimester, hence advisable to stop prior to the pregnancy. So the safest choice is the beta blocker and calcium channel blocker. And methadone, loop diuretic and hydrolazine can be used safely in the pregnancy. So for the in-stage patient who happen to be pregnant, the ESA, erythropoietin stimulating agent, considered safe in pregnancy. Iosucro also safe, heparin safe, and calcium base binder is safe. However, there are some medication in end-stage patient, if patient on sevelamer, lanthanum, or cinacalcet need to be adjusted if patient end-stage patient happen to be pregnant. Part of antenatal care is a pre-eclampsia prevention by starting a patient on low-dose aspirin 12 weeks onwards. Anemia with iron plus minus ESA if needed. Keep HB optimized at 10 to 11. So for the urea and biochemistry, which we have to monitor closely, target pre-dialysis urea less than 17 to 20 by intensify the dialysis regime. Which we aim more than 20 hours per week, about 5 to 6 sessions per week. And then fetal monitoring by serial growth scan and Doppler, thrombophilaxis with low molecular weight heparin, and postpartum care to review the medication and renal follow-up and put patient on contraception. So when do we consider termination of pregnancy in patient with kidney disease? If it poses a severe maternal risk, which is progressive chronic kidney disease with rapid deterioration, resistant hypertension, and severe refractory nephrotic syndrome. Meanwhile, for the fetal part, if it happen to have a severe IUGR with absent or reverse Doppler flow or non-viable gestational age with maternal compromise. So basically, patient with kidney disease, they comprise of 4 components, which is we should have a pre-conception part, which is individualized pre-conception counseling based on the kidney disease, optimization of the BP and proteinuria, medication safety for conception and pregnancy, and reflect if on the previous pregnancy if patient has been pregnant. So for the pregnancy part, once patient pregnant, UBT positive, found out to be pregnant, for early booking and BDT care with MDT care, and then put patient on PE prophylaxis with aspirin, also pregnancy safe medication, monitoring for pre-eclampsia, target for term delivery if possible, and induction and cesarean as per obstetric indication. So interpartum is we target for SVD if possible, and permissible. So with adequate and careful fluid monitoring and renal function monitoring, also management postpartum. So postpartum wise, we have to medication review whether we want to optimize antiproteinuria or need to restart certain medication that has been withheld prior pregnancy, and also need to monitor for disease progression or flare. So overall, take home message from the today's CME, pregnancy in kidney disease is high risk, but it's possible with proper planning. Multidisciplinary team can improve outcome. Outcome of pregnancy depends on pre-pregnancy renal function, presence of hypertension, and degree of proteinuria. So usually patient, women with mild CKD usually do well, but as a baseline renal function worsen, the risk of CKD progress and ESRF accelerates. That's all. Thank you.
Saya ucapkan kepada Dr. Nabila. Saya buka sesi soal jawab. Jika ada sebarang soalan, boleh ditanyakan terus kepada Dr. Soalan.
Thank you for the presentation on the pregnancy, kidney disease and pregnancy. I'm Dr. Amy from UIG. A few questions. Number one, a lot of our patients refer to us, and then our conclusion is that fail PPC or PCT, fail pre-pregnancy counseling. Number one. So how do you go about that? Did you include among all the 38 patients included in the study just now, did you study on that? Number one. Number two is, if let's say there was a patient last time increasing proteinuria 7 weeks, primary gravida, would you consider going for biopsy first rather than going for TO2? And what's the current point for you to consider the biopsy? Okay, in pregnancy. And then just information. Lately, we rarely receive a patient referred and receive a referral for PPC. Lacking of patients now, is it lacking of a CKD disease or lacking of referral? Just for awareness to get the activity regarding the importance of awareness, especially for those that already CKD. Set aside those diagnosed during pregnancy for the first time. Thank you. Okay, for the first question, among the 38 patient, actually, I got the list from the previous trainee. I have been here for 2 months, so actually we do not go through the pre-PPC. So the among the list of patient we encounter during patient already pregnant. So I have to go back and look back whether the pre-pregnancy wise, how's the disease state and what's the PPC status on that one. So I'm not sure regarding the 38 patient, because when I got the list, patient already ongoing follow-up for the pregnancy, and I had no I did go through the pre-pregnancy state. And then for the second question regarding the renal biopsy, usually we will work out for the secondary causes of proteinuria, which is the usual autoimmune screening. And then for the biopsy wise, it's not that we don't offer. And then most patients actually not keen for biopsy as far that my 2 months in here. So for the previous case, I have to look back and see whether the biopsy status in the this kind of polyclinical vision. And then for the third question, the PPC part, throughout my review, throughout my clinic review, for the younger age group, basically we ask regarding the family planning, and then we see whether the patient already on contraception or not. And then maybe we should emphasize more regarding the PPC in reproductive age. From the nephro part.
Currently, what is the policy on patients with kidney disease and referring them to pre-pregnancy clinic? Do you refer all, at least women with in reproductive age can? Do you refer all or selective or depends?
Ideally, kita probably would like to refer all as well yang macam tadi cakap tu memang kita akui our pre-pregnancy counselling is very lacking lah. Kalau tengok in that room, kita tengok kadang-kadang tu patient tu muda, macam contoh patient SLE kita banyak kali muda. In the visit clinic tu sometimes terlepas pandang benda dah pregnant, anak pregnant ke depan tu, kita target banyak okey tu, kadang banyak terlupa benda tu. Tapi saya akui memang betul pregnancy counselling tu memang penting lah, bukan untuk nephro saja. Saya rasa mungkin untuk semua medical base punya facility, ideally kita would like to refer patient-patient yang ada sebenarnya yang SLE contohnya yang memang active disease, kita would like to refer. Kalau untuk in terms of biopsy, macam Dr. Rin tadi, yes, we would do biopsy. Kalau continue ada more than 1 gram per day, 24 hours urine protein more than 1 gram, we would like to do biopsy. Satunya sebab kita nak tengok in terms of prognosis dia lah, ataupun kita anticipate what will happen in the second and third trimester tu. We would like to have actually exact diagnosis lah what's going on. Lalu kita biopsi, kalau boleh sebelum 18 minggu kita biopsi, pasti boleh biopsi. Lebih pada itu pun kita boleh, cuma technically a bit difficult sebab ada program yang sikit lah terpaksa buat lateral position. Tapi insyaAllah kalau patient yang agree, memang kita akan biopsi untuk patient yang ada ginolia.
Cuma satu concern regarding the patient tak agree, said that patient tak agree for biopsy mostly kan. Tapi macam mana dia boleh mudah agree for TOP? TOP is not without risk. So my concern is that there's a patient yang kita buat MDT kan, MDT semua patient ada fixed mind for TOP. Why kita nak revert back to go for biopsy at that point of time? So how could we have a better discussion with the patient so that they will aware TOP is also risk? Kan, banyak juga risk itu TOP kan, up to the risk of different information, for example. Jadi kalau kita every time of counselling, if we go by meaning that kita counsel during the entity, what is your opinion about that?
Saya rasa saya setuju betul. In terms of mentioning on the TOP tu, jangan terlampau awal lah bagi saya tu beri ya. Memang banyak pada saya tengok trend sekarang ni, kalau kita tengok kalau patient yang pregnant ada heavy procedure BP not control, dan terus kita bagi tahu mengenai TOP. This is our first approach lah. Kita bimbang kat
patient pregnant ni tak tidur 9 bulan, tak tidur. Kita kalau ada problem terpaksa HPD kan, kita selalunya bagi tahu the worst early on. Tu yang masalahnya. Bila kita dah beritahu worst what happen, what probably happen in second trimester, they normally we just opt for TOP rather than go through the biopsy and then treatment kalau perlu. Maybe kita boleh buat semula in terms of mentioning on the TOP tu, kita maybe waktu MDT rather than early on, waktu dekat ward atau dekat klinik.
Just to explain, I think just it's clear, I think there's two different issues between TOP and biopsy, depending on the kidney disease and depending on indication. Not all pregnant patients indicated for TOP. You see the list are almost 40% that we see patients who come with severe or CKD pregnancy that does not indicated for biopsy. Those that indicated for biopsy, like Dr. Zuhad said, those with heavy proteinuria, that we probably need to use immunosuppressive that is contraindicated during pregnancy. Especially that we have a lot of lupus nephritis who take in pregnancy. So that we really push for biopsy because we need to use the immunosuppressive or drugs that is contraindicated during pregnancy. So we do have patients who agrees for biopsy. I don't believe that all do not agree, but depends on the indication. But again, a lot of patients that we encounter, we have very limited time for counseling because they came relatively late. Because like Dr. Zuhad said, we have targeted if possible within the first trimester or within the second trimester, that it would be the procedure be relatively safer for both biopsy and evaluation. So we have that limited time. So if but we try to improve, if possible, we involve all within that short time, including evaluation.
Information, our basically is running daily on a daily basis. Do refer to us, even walking patient. Okay, thank you.
Kadang-kadang dekat apa tu, bila kita tengok patient mungkin pada MO kita yang ada di sini, always think about possible pregnancy. Yang contohnya patient yang muda-muda, macam Dr. Salwana dulu selalu kata, kalau mak muda, bapa ada, then kena fikir about pregnancy kan. So kena always think about that. Jangan terlupa, bila dah pregnant susah sikit lah kita nak start ubat and then nak bagi nak biopsy macam lepas kita kalau boleh awal kita boleh prepare dengan OAGD untuk kita for a safer pregnancy insyaAllah.
Jadi soalan saya mengasih baik untuk mengajukan soalan kepada penonton. Jadi saya kita ada 3 hadis semua baik agak yang cuba dengan
Okay, soalan pertama. Can anyone name one maternal and fetal complication in patient pregnant patient with lupus nephritis? Any of the maternal or fetal complication?
Preeclampsia IGR.
Yes, correct. So the second questions, what is the creatinine level that we allow consider allowed to patient to be pregnant?
Less than 100.
Correct. So, final question, between the HD and versus PD, which one of the preferred mode of renal replacement therapy in pregnancy? Yes. That's all. Thank you.
Sebelum kita mengakhiri sesi sesi pada pagi ini, saya ingin mengumpul tempoh Dr. Izamul Iqbal untuk menyampaikan sedikit perhargaan pada komunitas yang kita berada di persilakan. Sebelum saya terima dengan ini kita telah sampai ke penghujung CME pada hari ini. Untuk tuan-tuan dan puan-puan, CME seterusnya akan diberitakan oleh tetamu jemputan kepada unit kesihatan primer Jabatan Kesihatan di Kelantan Dr. Anis binti Azam. Untuk pengarah kanan unit kesihatan primer dengan tajuk perkhidmatan perawatan domisili di fasiliti kesihatan primer. Jadi dari ini kita tamatkan sesi CME kita pada hari ini dengan fasiliti farah dan sebagainya. Assalamualaikum warahmatullahi wabarakatuh.